Okay. Well, everybody, welcome to another round of Fit Foot U, and I'm very pleased to have a couple of my mentors tonight. The first is Dr. Pat Agnew. I finished up my residency. Ironically enough, I was all set to join the Air Force, and I don't know. I think I told this to you, Joe. I was set to join the Air Force on a package that was postgraduate. Another residency hadn't worked out, but there was a good trauma program out in California. Well, strangely enough, they got somebody that was already within the military to fill that spot. So they offered me something down in Texas at a diabetic clinic. And I had a lot of diabetic limb salvage at the Philly VA. Now my connection to Pat goes to, I was sort of scrambling to find a practice because I had worked with somebody for a year. It didn't work out. And I spent about half a day in his office, and then he kind of showed me the lay of the land in Virginia Beach. And I didn't end up purchasing that practice, but continued to maintain contact with Pat and his information that he was able to share with me about reconstructive foot surgery, conservative casting, and his treasure trove of knowledge of the great Jim Ganley. Now, my crosshairs with Dr. Agostinelli revolved around my rotation down at Langley Air Force Base. That was a partnership that Ann Sinoga, when she was the director there, started up. So I think the first way that I'm going to introduce this is you guys have both had military experience, and Dr. Agostinelli, I know you've done a lot of groundbreaking stuff in the military. Tell us a little bit about it. Tell us maybe about some of the forks in the road, decisions you made that you think were the right ones. And if you did some mistakes along the way, maybe some things that we can learn from administratively, or anything clinically that you were able to do to kind of put podiatry in the better stead that it is today in the military.
Sure. Oh, first off, welcome everybody. Hope everybody's safe with the pandemic, and hopefully we're getting our lives back slowly but surely. Pat is going to probably relate to a lot of this, what I'm going to tell you, but my kind of journey is a little different. I graduated in 1981 from PCPM, which is now Temple University School of Podiatric Medicine. And a year prior to that, I had a rotation at the Philadelphia VA, the old Philadelphia VA. And after 1 month there, I decided I'm going to volunteer. The way the vets were treated back then and my rotation back there with all the vets kind of spurred me on. I said, I got to do something. So my first assignment was at Wilford Hall, U.S. Air Force Medical Center, a 1,000-bed hospital in San Antonio, Texas, also home for the U.S. Air Force basic trainee cadets who did 6 to 8 weeks of basic military training before they go in the Air Force. They also had an officer candidate school there. And my first day there, I'm a young captain, and I walked into the colonel's office, an orthopedist, and he said, "Captain Agostinelli," he said, "your office is across the way with the cadets. You're never going to see the OR while your time here." And there was 25 orthopedic residents with the orthopedic residency program there. And that was my greeting to the Air Force. He says, "You'll have a desk, you have a phone, and go start treating your patients. Have a nice career." Did my assignments, and I noticed that every day there was an orthopedic residency lecture at 6:30 in the morning as part of their 5-year program, including their year of general surgery. And I went to every one for 3 years. And after going to these meetings a few times, they started recognizing me there and started asking me questions about foot and ankle stuff. And I was the first podiatrist ever to get to an OR at that place. One day I sent them I had to send all my surgical consults to the orthopedic residents. I wasn't allowed to take them to the operating room. And one day, one of the residents called me and said, "Hey, Joe, this is your patient." He said, "Number one, why don't you come over with us?" And I'll never forget, it was a bunion surgery. They didn't know how to start. And I just talked them through it like I was an instructor, having no experience in the military. And one day they asked me to give a talk on bunions. And I said, someday I hope I get to know you, you get to know me, because I'm going to be at a base somewhere and you're going to be the chief of orthopedics out there. We're going to be working together. And over a 23-year career, I outlasted every one of them. And I became a full colonel for the first time in the Air Force. We had that. And every assignment I had after my initial one, I was either equal in rank or higher rank than they were. And in the military, it was all about rank, not so much how well you did in medicine, but if you outrank someone, you were the chief of that clinic. And so because I stayed in and did what I was supposed to do besides my primary duties, I was able to get a lot of additional duties as chief of the orthopedic clinic, which never happened before. And progressed with my surgeries then, and was board certified very early in the military. I know Pat could attest to this. You get your cases very quickly for all that you needed. And back then, they think it's hard now. We had a pass rate of about 30% with the American Board of Podiatric Surgery at the time. And when I submitted my cases, I'll never forget, they would always ask you for about 7 or 8 cases to give a complete documentation to the boards. I was asked to give 18 cases of the 100 I submitted. And I kind of figured out why, because I was sending them some things that a DPM normally didn't see at that time. I had a lower leg, basically practice from the knee, including the knee down. In the military, our scope of practice was basically whatever you were allowed to do and prove that you could do something. So because of that, got involved with the American Board of Podiatric Orthopedics, was on their board of directors, ACFAS, American College of Foot and Ankle Surgeons. And I'll never forget, about 1999, I was able to get full admission privileges with history and physicals because I had enough rank at the time. I was on the executive committee of the hospital. And I said, I need to do my own physicals, be able to admit patients. And the American College of Foot and Ankle Surgeries called me and said, how did you do that? And I explained it to them and sent the letters I had, and they came out with a position paper that we should be doing that. So I'm kind of proud of that, because I really didn't do it for me. Believe me, I'm not that kind of person. I was always thinking, I'm going to be gone eventually. What could I do for other people that are going to follow? And it's funny how now, with the talk about the UCMLE and the parity situation, that started many years ago. And from that first day, my first assignment, being told, you're never going to get into an OR, and then winding up outranking everybody and becoming the chief of the surgical services at 2 hospitals. It was amazing what that did for the civilian sector, because a lot that we did in the military transfers over. For example, all the advanced cardiac life support, advanced trauma life support, trauma medicine in this country is established by surgeons who were in Vietnam originally and brought all that back to the States. And if you look at the large trauma hospitals, I will guarantee 50 to 60% of their staff had military experience where they saw all that stuff. So I kind of use the military a lot to not just have a great career for myself, but I think set the stage for others to follow, not only in the military and the VA, but throughout private practice. A lot of stuff that's happening now was being done in the military like 20 years ago. We're kind of ahead of the time, and I was glad I was able to do that at that time.
Would you say that, Joe, you were your own sort of self-contained unit, or did you really have a strong mentor? Or was it more that if you had something that was an ankle that you hadn't had experience, eventually, once you established that relationship, you could ask? But early on, it sounds like you didn't really have maybe a strong mentor, at least those first 3 years when you were going to the Grand Rapids.
It's funny. By the time my 3rd year was up, that person that told me that wrote me up for my first Air Force Commendation Medal. I got to be a good friend with him, and he was the chief of the program. And I understood where he was coming from, because during our discussions over 3 years, he said, you know what the problem is, Joe? He goes, when we have a DPM come to us, we don't know what kind of training they have. We have to ask, where did you go to your residency? What did you do? Show me a log of your cases. We did not have standardized training. Back when I graduated in 1981, we had PSR ones, post-surgical residencies. We had rotating residencies, which were non-surgical. We had very few 2-year programs, PSR 24s at the time. So I was able to gather all my experience from that orthopedic residency experience for 3 years, every day spending time, half the day with them, half the day in my own clinic. So when I did my first 3 years, I worked it out with this chief. I said, I need to have a residency on a paper. I need a podiatric residency. So the Air Force was nice enough to send me for a year to Philadelphia, where I did a year's program. I already knew what I had to do. I was just there to get the 12-month certificate so I could take my boards, and then just took off from that. So that's kind of why my situation is a little different. I went from graduation to an orthopedic residency program. 50% of the time did that, 50% ran a sports medicine clinic, basically. That was my emphasis on sports medicine, which spurred me on later. And here I am today as the president.
I didn't realize you had that crossover at the Philadelphia VA. Well, Pat,
Yeah.
you've been, I think, more crossing back and forth between civilian and military than Joe. Maybe you can tell us some of the stuff that you've seen crossover from military medicine to civilian medicine and vice versa, from your experience. And maybe just because we don't have a lot of time, you can give like a 30-second thing of your entry into the Navy.
I missed it.
There you are. There you go.
Yeah, I missed a couple of minutes there. I hope I won't repeat anything the Colonel said.
No. We're basically, he gave us a very succinct outline of how he was able to integrate and progress with podiatry and kind of move up the ranks. How did you see the crossover back and forth between military and civilian medicine in terms of techniques that you were able to share because you were in both back and forth?
Yeah, so my career started, and most of it was in the reserve. I was commissioned in the reserve while I was a resident. Talked to Ray Fritz about it, who's a Navy SEAL, actually made Chief Petty Officer while we were in podiatry school. I always wanted to serve. My dad was in the Battle of the Bulge, the Ardennes campaign. My uncle was flying B-17s over Germany and North Africa, and I wanted to do some service, and learned the Navy will probably be a real good choice with me moving back to Norfolk. And I got a commission in the reserve and served in the same unit with Fritz for a while. And he kind of made sure I had my hat on right and pointed me the right direction. And sometimes took me running and swimming in situations that were much more challenging than I was probably up to, but he's a beast, that guy. And I spent 3 periods of active duty, partly for Desert Storm, partly for the International War on Terror, and partly for Just Cause Panama. So in each of those situations, I had some forward position experience and also some third echelon experience or naval hospital experience. I wound up in a lot of really weird units. At one point, I had the command of a Navy CB battalion because they couldn't find a combat engineer corps officer to do it. And they figured, well, Pat could probably do math. He's a doctor, and I had already had service with the Marines, so I knew how to do infantry stuff. And so I have a CB warfare pin. Now, Dr. Rulin was on a minute ago. He's the only guy in the Navy with a Fleet Marine Force combat designation. I got a Fleet Marine Force ribbon for serving with the Marines for 3 years and wearing a short haircut, doing a lot of extra chin-ups and running a little further. He got an actual warfare designator in that. And of course, Fritz has a Trident, a SEAL team.
We lost Pat for a minute, maybe. Let's see. He's
other podiatrists too, served in forward positions. You hear me okay?
Yeah, you're good now.
Yeah.
Yeah. So that's just a thumbnail sketch of my career. As far as the relationship between military medicine and private practice, it's agony and ecstasy. On the one hand, it's not easy to take a couple weeks off and go elsewhere to do your reserve duty and be away one weekend every month. And it does make it a little bit challenging to make a living in a private practice. But the experiences I had at those times and the time I did active duty for special work during Desert Storm, And the time I was on active duty for a year in support of Operation Enduring Freedom was, financially difficult, but the experience is working with 10 orthopedic residents at the Naval Hospital and being the senior guy there at the time. I guess I was the senior podiatrist at the time, was irreplaceable. The leadership training that they give you in the Navy, we're medical service corps. In the medical service corps, about half of his administrators, former chief petty officers, former senior corpsmen who they made officers, and so they could run the naval hospitals and run the fleet hospitals and all the things that the Navy does in medicine. And you're kind of expected, I guess, as a medical service corps officer to have some administrative acumen, even though if you're like me and had none whatsoever, and you got thrown into leadership positions. I had been in the Navy about 5 minutes and I was the executive officer of a Fleet Marine Force medical battalion. And so those experiences forced you to learn real fast on the job.
Yep.
And then they have formal training. Like we had a Harvard run senior officer course when I was commander, getting ready to go up to captain up in Bethesda, and had guys come down from Harvard Business School to teach us, they call it a beauty school, teach us
Right.
when we become senior officers. I may or may not have passed that test, but I sure learned a lot from those guys.
I got to ask you though about your main mentor, James Ganley. Now he was in the Navy also.
It was, and there's a great.
And so you did your training with him prior, right? And was that one of the things that also made you think about military medicine?
Yeah, it didn't hurt at all. I was already commissioned right when I started my residency.
Okay, so it was already a done deal. Yeah.
But Dr. Ganley was real happy when I went in the Navy. No
Yep.
disrespect, Colonel.
Tell me a little bit, because there's so much to share. You call them Ganleyisms. What are some of the things that you learned about life and practice? But then some of let's start general, and let's get to some of the meat of some of the clinical skills and things that you learned from him about dealing with patients. You can just kind of rattle them off as you see the most important and influential things.
Yeah, so Dr. Ganley had an opportunity to be a commissioned officer in the Navy, but he chose to be a senior enlisted guy right off the bat. They gave him some advanced rank and put him to work in an orthopedic clinic at Naval Hospital, Philadelphia, under a guy named Bundens, an orthopedic surgeon who side by side he did a whole lot of surgery with. And that, I think, was an introduction to Navy medicine of what podiatry could do, much like Colonel Agostinelli gave his introduction to the Air Force. Also, you may or may not know Dr. McGlamory is probably still in the Army National Guard, I think. He's a
Brigadier General.
General in the Army National Guard. Yeah, so different podiatrists have risen to surprisingly senior positions in the U.S. military and put a real good face on podiatry in federal medicine. It's an area of parity, or we really get treated as equals in the Navy, at least. There's not a whole lot of fighting over who gets to take care of what. There's mostly about who's available to take care of what, and there's plenty of work to be done all the time.
Jim, the story I have of Dalton McGlamory, Dr. McGlamory. I'm where I am as a retired colonel collecting a pension because of Dr. McGlamory. He convinced the Surgeon General at the time in 1975. The Air Force did not have commissioned podiatrists. The Navy and the Army did. And he argued and sat with the Surgeon General, 3-star general, and argued that not only do we need them in the Air Force, we will train them by paying for their podiatry school and their residency to be commissioned officers. That started only because of Dr. McGlamory. That's how the Air Force started. In the Biomedical Sciences Corps, which is similar to the Medical Service Corps in the Navy. So I think, even though he was an Army Brigadier General, he was the father of Air Force podiatry and started out with I think, 47 podiatrists. And now we have 19 active duty only, which is amazing. But he started all that. And I think he's still around. He's retired now. I think he's in Florida somewhere, from what I understand. But he deserves a big kudo, as Dr. Ganley, who always, as you know, talked about his experiences in the military as a Navy corpsman and what he did then. He did that as a lecturer at the Philadelphia College, I remember. So those two names, I think, are on two of the Mount Rushmore for us in the military.
They were actually classmates too.
Yeah, I didn't know that. They were classmates.
Pat, what
Now-
do you think though that you picked up clinically from Dr. Ganley? What were some of the things that still stick with you every day you're in the OR or every day you're in the clinic?
Yeah, I'll try to stay on task. I know the Colonel and I could tell sea stories for the rest of the night and into tomorrow. But gosh, all the different day-to-day practical things.
It's good.
Dr. Ruin, I think Commander Rulin wants to say something.
Sure.
Go ahead.
You want to say something now?
Maybe,
No,
go ahead.
Good.
Yeah, so Dr. Ganley had a lot of practical business things. He talked about like the 80-20 rule, like 80% of your patients are easy and the 20% are going to take up 80% of your time. He talked about the 1 to 5 rule, where if you satisfy one patient, they'll refer you one patient. If you dissatisfy one patient, they will defer 5 people. He talked about how when he would go to Australia to lecture, people were like, "Oh, Dr. Ganley, famous Dr. Ganley with 100 published papers and had a surgery at Temple," and he'd go around the corner to an unfamiliar hospital and run into a colleague, and they'd say, "Well, yeah, never heard of that guy Ganley. He's like a block away from his office." So those are some examples of the business acumen that this very classic Irish sort of practitioner carried along.
Did he take casting to a new level with pediatrics? Was he pushing the envelope with that, or was that just a movement that was happening at the time? And he was
I think the fact that a podiatrist was doing that was very new. After the Navy, he got a job at Pinehurst State Hospital up in Philadelphia, or outside Philadelphia, back when they had state hospitals. And this was full of severely and profoundly disabled children primarily. And he took the principles of Hiram Kite and went into that hospital and started treating these severely crippled children and getting a lot of them up and walking where they never would have otherwise. And that was probably one of the very early adventures of a podiatrist doing that, and doing it again in a government institution where it's noticeable, where higher up people who make decisions about funding and programs and things like that get to see things happen.
I have an interesting, one of my mentors, you mentioned about mentoring. My first assignment after residency was at Wright-Patterson, United States Air Force Medical Center in Dayton, Ohio. And the chief of orthopedics said, I was a major, he was a major, but he outranked me by time in. He was there. And one day I had a bunion on the schedule. And he goes, "Hey, do you mind if I come in with you?" He said, "By the way, you know who my mentor was when I went to Henry Ford Hospital in the early 60s? Dr. Leslie Mitchell from Mitchell Bunionectomy."
Oh, okay.
And this person, chief of orthopedics, his co-chief residents, they had 2 at the time, Dr. Kent Wu. If you remember, he wrote a book on bunion surgery way back, one of the classics, before the DPM started writing about it. And I'll never forget, he said, "Would you like to learn how Dr. Mitchell showed us to do the Mitchell procedure?" He did that one time, and I remember I was one of the few DPMs that ever did Mitchell procedures for many years, rather than mostly it's the Austin Chevron procedure, right? Which is mostly a DPM originated procedure. And I'll never forget that day when we walked in there explaining someone who actually was trained by one of the classic procedures of which we base every other distal osteotomy that has been a modification really of a Mitchell, if you think about it. And that always stuck with me, that I was lucky to learn from someone like that, who had it handing it down from the hand of God, you know, to Adam for life. It was kind of funny. And I used to lecture at that with the Mitchell procedure, and I get all these kind of looks because we were, if you remember, that was kind of talked down in school. And the orthopedist, you talk about what you learned from them. I'll never forget, one of the older orthopedists used to say, he said, Joe, when you get out there, there's probably 75 different ways to do foot surgery and bunions. But he said, let me tell you, all you need is 3, a McBride, a McKellar, and a McKeever procedure. He told me that like in 1984, which again, if you think about it, a lot of our procedures are based off those classic procedures. And I kind of got involved with that. If you look at what we're doing now, really nothing is really new. If you look back, even in the early 1900s, you'll see 75 ways to cut a metatarsal bone with an osteotome and a mallet. And it's kind of fascinating if you look at that. Everything is like a modification of a modification of a modification. So I think the key word is not competition with orthopedics, it's complementary with them. And I think you're seeing more of that now as DPMs get into orthopedic practices, which basically Pat and I had in the military our whole career.
I want to tie something else that I observed while I was down there on the rotation, and that was you did a lot of I wouldn't quite call it cookie cutter, but you did kind of, the military forced you to be expeditious and to use a good clinical, practical tool that you could get done that day and get started. And I remember you using, I think were they Alimed?
Those
Alimed inserts. But here's the thing I wanted to blurt out, and I can't remember how they were posted, but just last week I had Doug Ritchie talking about kinematics of the foot and about all our notions about posting, and there's not a lot to kinematically validate varus posting in the rear foot, valgus posting in the rear foot, and a lot of other long-held notions that we've had back from Merton, Root, and Weed. And furthermore, I mean, he did talk a little bit about some of the influences of valgus, forefoot valgus posting, but tell me a little bit about what your approach was with those dispense of the Alimeds, what they were basically
it kind of goes with what Pat made a comment before, Dr. Ganley made a comment about an 80-20 rule, which I think is called Pareto's rule in algorithms. There's also one we had, it was an 85-15 rule that was told to me by Dr. Harold Schoenhaus, professor of biomechanics at Philadelphia, that I carried into the military. And I was a big prefabricated person over custom molded orthotics. And our rule was 85% of the problems you have with feet, if you're going to use orthotics, you could put anything in the shoe to stop some kind of motion that's causing pain. And 15% of the people you might have to work with basic biomechanical type orthotics. So in the military, we had these prefab orthotics that Pat will remember, used to pass them out like M&M candies, which was Motrin we used to pass out. Motrin was M&M candies. And we passed out these orthotics that, if you look at a prefab orthotic.
Hey, Joe, are those your grandkids that are playing Cowboys?
No, that's not me.
Oh,
that's not me.
I wasn't sure who I don't have muted. No. We're getting a lot of
if you think
so
about
whoever's got the kids playing Cowboys and Indians, please keep yourself if you're not. Well,
it's fun though. But think about your posting. You mentioned about posting. If look at a prefab Alimed or a Foot Smart orthotic, it's about 5-degree rear foot post, has a nice arch, and it's comfortable. That's basically what a prefab orthotic is. It's usually about 5-degree rear foot post and a nice arch support, and that's all a prefab is. And we have so many different kinds of prefabs. Spenco, we used to use a lot of that in the military. I think we were the largest dispensing of Spenco products, heel pads, metatarsal pads, and orthotics of prefab nature were the military, was the DOD. Almost every other patient in basic training, almost every patient was given.
Pat, tell me about some of the advanced things that you did in the military and maybe today with pediatrics. I mean, do you see a lot of with the families in the military, and how did you integrate some of the things that you learned from Jim Ganley with that.
Sure. I'm going to make a quick digression. The guy you were hearing as children is Dr. Joseph Lynott, who's online here, who was a corpsman serving with the Marines in Operation in Iraqi Freedom. And
Wow.
we shall
Thank you for your service.
Yeah, and glad you made it.
You're welcome. Thank you.
Yeah, welcome aboard, Joe. And keep it on mute.
Good on you.
Hey, before you launch, we're gonna take a, after you say what you're gonna say, Pat, we're gonna take a 1 to 2 minute water bathroom break, and then we're gonna re-sign on for Q&A. I want to make it a little more interactive. We have probably some of your colleagues that might want to interact. I'll probably ask a couple more questions in the second format, about 20, 30 more minutes after this, but we're gonna be timing out in about 2.5 minutes. But go ahead, Pat, continue.
So most of the kids I treated in the military were in other countries as part of medical civil action programs. This is a mission that actually belongs to Army Special Forces, but they often take healthcare providers from other services into the field to treat people in contested areas. In our case, the Iron Triangle, which is coveted by Al-Qaeda from Malaysia, and protected by multinational forces as best we can to try and, number one, get them to stop growing so much opium up there, and number two, avoid having terrorism. It's through narco connections fund their terrorist activities. But we did a lot of kids in Southeast Asia and other parts of the world that we can't really talk about much, but these kids would have horrendous birth defects, snake bites, all kinds of bot fly infestations, just crazy tropical medicine things that I didn't get to see much in my private practice. But you know, a lot of what we know about things like clubfoot casting and other types of pediatric orthopedic intervention translates well into mission work of that nature. And is greatly appreciated because a child with a clubfoot in a very rural third world country type setting is lost. He's basically useless to his family. He's stigmatized. His life's ruined by that birth defect, and that's something you might be able to fix.
I want you to hold that thought and tell us about some of those experiences. And then while we're on break, somebody asked about females in the military. And I think that's an important thing that you can both share your experiences about the strides that female podiatrists have made. And you're on, sir. Go ahead.
Excellent. So I was just saying that some of the things we're talking about tonight, I don't think are written down anywhere except maybe in somebody's service record. And I think these are important little bits of history that I hope, well, maybe when I retire, I'm going to write as much as I can about it. May call up the colonel and collaborate. I hope you'd be interested in that, sir.
Yeah.
But you know, you can't leave out in a discussion like this tonight names like Brad Winstrup, Colonel Brad Winstrup, Representative, the Honorable Brad Winstrup, the U.S. House of Delegates, Congressman, who actually, saved a life under fire at a softball game in Washington just a couple of years ago. Used his military training to go out there and put a tourniquet on the leg of a guy who would have bled out on that softball field. And you can't leave out guys like Rob Sullivan, who, like you talked about, Colonel, when I first graduated from my residency, he'd invite me in to operate with him over at the Naval Hospital and further refine my skills and gave me the opportunity to sit for my boards in 1990 after graduating in 86. And I don't know, maybe 10% of my class of 86 had enough cases put together to take their boards at that time.
Yes.
And that, got me boarded in 1990, which was just in time to be grandfathered. So I don't have to get recertified, which is awesome.
You mentioned emergencies and vital medicine. How much did the military experiences have to do with any associations and rotations at ERs at community hospitals? Was that, or do you think
Yeah.
that was more just established? We've established a podiatry residency and now we have an ER rotation. But you mentioned that, Joe, that there was a big, that some of these trauma things were direct Vietnam things. So I'm wondering, from your guys' perspective, and I don't want you to overstate it, I don't want you to understate it, but what do you think the link up was with podiatry ER rotations?
It's different with the Air Force. I don't know if this was in the Navy, but we had a 6-week course at Baltimore Shock Trauma Hospital. It was called C-SPARS, and I forget what that meant, but it would send the surgeons to a 6-week course. This is interesting, for treatment and debridement of gunshot wounds, blast wounds. Now think about this. In peacetime, in the military, you rarely see that unless someone comes into your ER at your hospital. But
I was at Girard and we did see a bunch of that.
That's right.
You'd hear things, and then the ambulances would roll in. But usually you're right.
This is interesting, where we sent our docs, and I was able to go. One was in Baltimore, one was in the University of Miami, the other was in Las Vegas. Those were the 3 places that had the most gunshot wounds that the Air Force did a study. So they said, well, before we send our people overseas to take care of blast and gunshot injuries, they need some hands-on training. So they established these training with these large hospital centers that majored in trauma for 6 weeks. We also had a course, and I think Pat might remember this course. It was called the Combat Casualty Care Course, which you're nodding your head, which was at Camp Bullis.
Yeah.
And ours was at Camp Bullis outside of Fort Sam Houston. And I remember I had a fight to go to that course. Why is a foot doctor going to that course? I said, because every other person in the operating room besides me was eligible to go to that course, including the OR nurses. Makes sense, right? So I fought to go, got to go, and now you could go if you're a surgeon, which again, Pat will understand this too. In the Medical Services Corps and the Biomedical Services Corps, they are not the medical corps. You see, that's the parity thing that we're still working on, that is going to be a lifelong process, that podiatrists as DPMs, if we're going to be equal to physicians, then in the military, you need to be in the medical corps, which opens us up to the specialty pays. Because the biggest frustration as a DPM in the military is pay. You're paid by your rank, what it is and how much time in, and if you're board certified or not, you get a bonus for that. So when I was a colonel, my last year in the Air Force, 2004, I made the same amount of money, cash-wise monthly, as a captain orthopedic resident coming right out of the residency because of the specialty pays. That's the biggest problem with us, was being able to pay back your loans now. When I graduated, I had a $35,000 loan. That's what I had. And it took 10 years to pay that on a captain's salary. That was $16,000 a year as a captain in the Air Force in 1981. When Pat started, you could relate what it was then. But that's what a captain's salary was. For a DPM in 1981, you got paid as a captain, whether you were a captain supply officer or a captain foot doctor in the Air Force. And you mentioned before, Ben, about women in the military. Back in the 60s, unfortunately, if a woman was in the military and became pregnant, they had to leave. So there were no DPM or other surgeons in the military or physicians until the 70s. And I know now we have in the Air Force, we always have about 20%, 25% female DPMs with us, which is great. You know, we need that. But at one time, we're not allowed to be in, which was interesting. And I remember the first group of 47 DPMs we had no women in that initial group of DPMs. It took several years, about 10 years before that came to fruition. And now it's totally open to everybody.
Yeah,
I don't know about the Navy. You can relate to the Navy.
2 quick anecdotes. Navy pay is very similar, but the reason you can now get board certified pay, at least in the Navy, is because Commander Fritz put on his white uniform with his SEAL trident and went and testified in front of Congress. And they probably saw that seal pin on his chest and were afraid to say no. So they granted board certified pay to at least Navy podiatrists. Anecdote about a female podiatrist, Dr. Sonia Courage, I think finished up as a lieutenant, but she was at Bethesda Naval Hospital for a while, now Walter Reed, and she, or part of Walter Reed's greater catchment area. And she was deployed in OIF, Operation Iraqi Freedom, and was ambushed, dismounted her ride, and returned shots and fire in anger. One of few podiatrists, I think, that have been in combat, and a female at that. She also worked at Camp X-Ray in Guantanamo Bay, where she was very useful, having some language skills down there, and also, of course, her medical skills were very valuable.
In the Air Force, we had the only colonel or captain in the Navy rank, Claudia Sands, who we recruited in the early 90s, the late 80s, early 90s, and she became a full colonel, first female of that rank as a DPM.
All right, now I'm going to put
That's the mother of podiatry for female.
I'm gonna put you both on the spot academically, and there is no right answer for this, but I want you to think about this. You see a lot of wounds in the military, and I know, Pat, you've been a big advocate with regenerative medicine, some of the amnion growth factors. You've seen what they can do. You've seen VAX. You've seen all that stuff. Just recently, there was a CAC committee. It was national, and they're usually not too often national, these Medicare review committees. And they were looking at amnion in particular for orthopedic, not wounds, but for orthopedic type problems with injections. I've used them. I'm a believer. I injected my own Achilles when I had an injury. So it was, Dr. Heal Thyself kind of a scenario, but it was part of my healing in my mind. What do you guys make of the consensus that came where they said, there's really just equivocal studies. We don't have enough there. You've both seen these review things in process in the military. Now, this is a Medicare thing I'm talking about. Pat, why don't we start with you, since you were intimately involved with the mimetics study that looked at, I believe it was plantar fasciitis, if I'm not mistaken. Give me your perspective on, what that does for the future of getting insurance pay for regenerative medicine. I don't think it's the end of regenerative medicine, because obviously there's cash pay as well, but give me your perspective on that kind of consensus meeting that came out. And I don't know what the final ruling in terms of when they are supposedly halting Medicare payments for a few of these companies that sought that Q code coverage for amnion. Give me your thoughts.
So full disclosure, I've done multiple clinical research trials for a half a dozen different companies, including mimetics, and I'm a former speaker for mimetics. Before I was doing clinical trials, and I stopped speaking when I did clinical research. And we did have a paper published. I was a co-author in Foot and Ankle International, probably one of few podiatry co-authored papers to show up in that particular journal. And it did show excellent results in treating plantar fasciitis over a reasonable period of time. And I'm a big believer. I also tell you that the military is always looking for a super Band-Aid, and is very interested in a number of different, like diabetic or wound dressings, like Kerecis, whom I'm a speaker for right now. And it's being studied by the Department of Defense, as were mimetics products. They even took a mimetics piece of Epifix and put it in a guy's backpack in Afghanistan and measured the temperatures in there. It was like 140 degrees inside of his backpack. Took it out and used it and found it still had all its growth factors and everything. So they're always looking for something field capable, like your Hoffman devices that you might use as an external fixator. Those are designed to go out of an airplane in a backpack.
Yes.
These kind of innovations, you can't overemphasize the relationship between military medicine and advances in civilian medicine. Everything we know about prosthetics right now has exponentially improved because we've been at war in Afghanistan for 20 years, a war that our enemy has realized that it's better to wound somebody than to kill somebody. If you wound somebody, two guys got to carry him back. If you kill him, he's just dead. And the two guys will be returning fire instead. So they design anti-personnel devices to wound. It's actually old dogma from the Warsaw Pact. Our former Soviet enemies knew this too. And so a lot of devices are designed just to wound. And the idea of being able to get people to heal faster and heal with something you can carry out into the field is enormous. And I think regenerative medicine has a big role in that for the military. We just published a paper in the Journal of Foot and Ankle Surgery. I was a co-author in a group that made clinical consensus guidelines for Achilles tendon injuries. We found out that really you probably don't need to operate on many Achilles tendons, pretty rarely. But if you do operate, you can sometimes get someone back to competition quicker as an athlete. And we were sure to put a little paragraph in there. I insisted that they put a paragraph in there that this is also true of military. If you injure your Achilles tendon in the military, you might be more likely to get surgical treatment because you might get back in fighting shape quicker. And this is important. It's a dangerous world out there. I don't know if you've been watching the news, but there's a lot of stuff going on. And getting people back online, ready to fight faster is always critically important.
I want to ask, I want to change directions for just a second, and then we're going to probably open up to questions because I know there's a lot of your colleagues out there. When I was talking with Doug Ritchie, and this is kind of right on point with your Achilles work that you did, Pat, he was talking about this measure that was done in Europe, I believe, this Achilles resting angle, where you're prone, you put the knee at a right angle, and that angle, you can compare it to the non-injured side, and both for surgery and for detecting an Achilles rupture. And I know that, Joe, you and I were talking about how there's so much rush to MRIs, but that we've lost a lot of our good provocative diagnostic tests. So I'd like each of you to tell me one diagnostic test that you think is overlooked, and it, not as simple, obviously, as a drawer sign, something a little more out of the loop that might, be something that people can pick up and learn from, that you did in the clinic, or that you found useful enough, whether it be for a flexor hallucis injury or whatever, that you thought was something that people might benefit from without rushing to an MRI, for instance.
Yeah, that was, as Ben knows, that was a big pet peeve of mine. We've lost some clinical acumen, unfortunately, especially with Achilles tendon and suspected ruptures. There's so many different tests, and what we used to do was, if you have someone just even supine, with let's say they're flexed at the pelvis area and their legs are on the table, and you just look, you're supposed to have both feet plantar flexed a little bit, the same amount. And an Achilles tendon rupture, one of them is going to be either at 90 degrees or dorsiflexed, and it's going to look different than your other one. And it was so funny how we get blinders on. Someone comes in with a, quote, sprained ankle on the right. Do you even take off their shoe and sock on the left side to compare? We are symmetrical. You should look exactly the same. And that's a simple test that we did. We didn't do the Thompson test, the Simmons test. We just looked at them on the table without shoes and socks and rolled up the pants, and we look at the feet, and you could tell right off the bat. You run your finger around the back of the Achilles tendon, you'll feel a divot, and you don't have to run off and have an MRI for that. Although in the private sector, you get an X-ray because of their, quote, ankle sprain, you get your MRI, and then you proceed with what you're going to do. When, if you think about it, when you diagnose it from your clinical exam, is it going to change what you're going to do by getting advanced imaging testing? Chances are no. And as Pat could tell you, especially in a deployed situation, you don't have any advanced imaging. You don't have imaging at all for things. And you have to have a clinical acumen to pick things up by your hands on the patient, which is less and less being done over time, I think.
Now, I do want to throw this out. Those GE ultrasound units, one of their selling features is these were on the battlefields in Iraq. Did you guys see diagnostic ultrasound on the, being used in the field? Either one of you did?
Have not. I have.
Pat, have you seen that, or is that more of a selling point for GE?
Well, they may have carried one out there. I don't know
Okay.
if it got used.
They might have had one.
No disrespect to GE, but
No.
I gotta echo everything the Colonel just said. And a quick anecdote: I was in a third world environment, and an Army support tech. Tech sergeant injured her ankle, and we used the Ottawa criteria to properly diagnose her because the closest X-ray was a day's ride away in a Humvee.
There you go.
And
Can you just list those for us, Pat, just for the people that are not educated on the Ottawa criteria or some of the points about the Ottawa criteria?
I'll just say look it up.
Okay. That's fine.
And I'll also, as a frequent defense expert, tell you, if you got an X-ray machine, use it. If you got an ultrasound machine, use it. If there's an MRI nearby, use it. You know, your biggest way to lose in court is to not take advantage of the standard of care in your community. But the standard of care in a Southeast Asian jungle is a little different. And the ability to make a proper diagnosis in that environment is an art that can, I think, best be learned in a military uniform. So if you really want to learn how to understand things, put yourself in those environments, or put yourself on a mission trip. Get out there where it's an austere environment, maybe a dangerous environment, and learn how to do the same kind of things you want to do in clinical practice, and rely less on what's available in your first world academic teaching center. Yeah.
I see a comment that there was some handheld units that Alberto mentioned with ultrasound. I did want to throw this out to you about my belief that ultrasound is still something underutilized, perhaps in the military, perhaps in the sports medicine field. There's so much that we can get that I think is in some cases superior to MRI. Obviously, if it's bone, MRI is going to trump what you're going to be able usually to do with an ultrasound. One of the things that I learned recently is how valuable a tool ultrasound is with gout. There's something called the double contour sign. So when you put the ultrasound probe up to the first ray, up to the MTP immediately, you'll get a refraction from the gout crystals that'll look kind of like a rainbow right over the surface of the bone. And it's called the double contour sign. You can look that up. And John Casualty told me about that. So I think there's a lot of more low cost available clinic things that we could be doing that sometimes we pitch over to something because either we haven't taken the time to investigate how we could utilize the tools we have, or we feel we have to, paper our chart with an MRI. Is there anything, Pat, that you felt or you feel is overlooked in how we're assessing just our clinical exam with kids? Maybe one or two things that you think are often overlooked that you could share.
Yeah, thank you. Gosh, I could make a lot longer list than one or two. Saw a kid today who has been told, his family's been told, this is a 7-year-old, that they're going to outgrow their intoing. And, this could really open a can of worms, and people can point to a lot of data. But I used to put on my military uniform and go to the American Orthopedic Foot and Ankle Society meetings. And they just smile at me and say, welcome aboard. They had no idea that I was a podiatrist. They just knew I was a lieutenant commander, I guess, at that time. And I walked right up to Lynn Staley, who is probably the most published pediatric orthopedist anywhere. and did these huge studies on things like in-toeing and flat feet and collected a lot of data. And I told him, I said, Dr. Staley, your data is so precious. Thank God you collected all this information. But I got to say, I feel like you keep drawing the wrong conclusions. Just because something is common doesn't mean it's normal. If that were true, we wouldn't treat nearsightedness, we wouldn't treat overbites. So your conclusion that we shouldn't be treating things like flat feet and in-toeing in infants and children just because they're common, I think is incorrect. And we had a good intellectual discussion about that. If you look at military people and you look at incidents of things like knee pathology, and then you work backwards from that and look at things like tibial torsion. There was a clinics in orthopedic related research probably 15 years ago that showed a very high incidence of things like tibial torsion in knee pathology. And they were bringing this up because they wanted to make sure it was addressed properly in a surgical setting. Well, there's a little bit more you can extrapolate from that. Like, hey, maybe all this knee disease didn't just fall out of the sky. Maybe it started in infancy. Maybe this grown up as a child was born to get knee pathology, which maybe could have been obviated with a simple splinter or cast early on. So the one thing I would say to anybody who works in pediatrics is prove it. Any statement they make, they're almost certainly not going to be able to prove. You're going to point to some data, some anecdotal data, some level 3, level 4 series, and say, well, this is why I don't treat flat feet, for example. But there is not definitive scientific data on this. The military used to prohibit you from serving if you have flat feet. But a bunch of Canadian doctors lined up a whole bunch of 19-year-olds and asked them if their feet hurt. Same guys, Harrison Beath, same guys with that x-ray view. And they said, and you ask a 19-year-old if anything hurts, and unless you hit them in the head with a brick, they'll probably say no. But these kids, they said, nope, their flat feet didn't hurt. So guess what? A lot of Canadian kids went to World War II, while a lot of American kids sat home. 4 Fs, yeah. And of course, we know now that flexible flat feet can be very functional. In fact, if you look at Israeli Army recruits, they have a lower incidence of certain stress fractures if they tend to overpronate. Now, that doesn't mean Israeli Army recruits don't get top-line footwear. They get good boots, good jungle boots with firm arch support. But flat foot's not necessarily, it shouldn't necessarily keep you out of military service, and it shouldn't be overlooked in an infant or a child either. We should admit that our data is terribly lacking in quantity and quality, and we should draw our opinions and conclusions over the entire life of a patient, not just look at snapshots and what percentage don't no longer have flat feet when they're 6 years old. These are silly bits of data that don't prove anything.
That's very hard to do in a military practice where you might see your kids for up to 3 years and then you go to another assignment and you lose it. And I remember do you remember the Crames communication booklets years ago? There was one I'll never forget. It said basically about torsional deformities, lower extremity, flat feet, in-toeing, out-toeing, and says things not to worry about in growing kids. I'll never forget that. And they used to pass that out to everybody. And the way it was with us in the military, and again, different kind of training I had with orthopedists, we didn't worry about flat feet until the age of 3 when they start walking normally, other than you get rid of your toddler walk at that time. And when you think about it, kids don't need shoes until they're 3.
True.
And so all the kids have flat, supple, flexible feet. Now, Pat made an interesting concept about the knee pain that we saw in the military a lot. Most of it was, to me, what we used to call, I don't know if they still do, malicious malalignment syndrome.
Mm-hmm.
And if you look at malicious malalignment syndrome in let's say a Netter book, if you remember our Netter drawings, how did they become that way? Probably because of the problems Pat's talking about. They had in-toeing problems and now they compensated, and now they have malicious malalignment syndrome as a 18-year-old. And when we see them the first time in the military, and the assignment I had was basically to bounce people out of the service because of severe flat feet that was causing a lot of shin splint and foot pain, and they couldn't complete their 6 to 8 weeks of basic training. I remember being the grim reaper over that, having to really get rid of people, because we would say, if this person is hurting because of their flat feet during their initial 6 to 8 weeks, when they're standing around waiting and running, what's going to happen with their medical record? How thick is it going to be like that when they're 25 years old and the Air Force or the military is paying for all that? So that was the philosophy we had with flat feet. If you had flat feet that were symptomatic and you complained about it while you were in basic training, you basically got a ticket to go home. I don't know if that's changed.
I think it's still true. Yeah, if you haven't made rank pretty quickly, if you're not a petty officer already and you're complaining of a flat foot related problem, you're out. And
medical
that's probably a good thing from a federal funding standpoint. You know, the largest healthcare system in the United States is the Veterans Administration.
Yeah,
and the Veterans Administration, the Veterans Administration is the biggest part of the biggest part of the budgets of the Department of Defense, and a lot of what they're doing is knees and hips and feet of veterans who went in with inadequate biomechanics, beat the tar out of themselves, and then wound up being a liability from a fiscal standpoint. Now, I submit that better screening initially or better early treatment could obviate a lot of that disease. Good pair of orthotics in boot camp, maybe a flat foot surgical procedure for somebody a little bit more senior who we've invested a lot of money in. You know, training a Navy SEAL costs millions. You know, these guys are strategic assets. They're worth the same thing as a nuclear missile, and they're every bit as dangerous in the right circumstances.
If you remember,
real quick, guys, because I want to give Alex a chance to ask his question. What do we do? And just real quick, what do we do then about trying to connect some of these things that happen out when people are released from the military, such as my back, my knees, when we all know there's not a lot of direct evidence that we can follow longitudinally to tie it in, and yet we know that there's an impact. What's the best way when I have a couple reports I'm writing now for, you know, interestingly enough, 2 ex-military guys that both had flat feet for different conditions that, you know, they got, let's say, 20% disability for their back, but are looking for more, you know, related to their feet, some, you know, directly to their feet, either the plantar fasciitis didn't get picked up. What are some of the things that that you might point to make those connections?
For me, it's easy. And I do a lot of this too for vets. It's documentation while you were in the military.
Specifically while you were in.
You have to show that you had flat feet, they hurt, and you were treated for that, and it was at what's called, the key word is aggravated by service. And that's very subjective unless you have documentation that shows, you know, every 3 to 4 months you were seeing the podiatrist, orthopedist, or your family practice doc because of foot pain, limiting your activity or to do your daily duties in the military.
All right, Alex, go ahead. What's your question, sir?
Thank you so much. I'm sorry to just jump into the Q&A. So I'm in Philly. My power's out.
No, but
I'm on 2% battery on my phone. So I'm a first year at Temple. I'm talking with both the Air Force and the Navy. I'm doing the 3-year HPSP program.
Oh, good. That's real good.
It's awesome. And my question is really, it's kind of a 2-parter. So podiatry is not included in the HPSP. It's in the HCSP, I believe.
Yes.
Right. And it's weird because with every recruiter I talk to, whether it's the Navy or the Air Force, you know, it's been on my radar for so long. All I've ever wanted to do is go to Buds, do the whole Navy program, but it's like life just didn't take it that way. So that's it. So I'm in podiatry school now, trying just to double dip with it, you know, scratch that itch of serving while at the same time being a medical professional in life. And it's weird because they both branches are saying the same thing, where there's no need for podiatrists right now. So my question is, obviously things might be different now in 2021 where the need might not be there. And if they're telling me straight up that, you know, we don't need podiatrists right now. Should this still be something that I put my name on a document? You know, it's a scary thing. So that's my question.
Yeah. I think what they mean is right now they have no open positions to be recruited. And I want to see what Pat thinks of that, because I used to do that and recruit, and you have to have what we call a need for that year. For example, I would, as the consultant, talk to the recruiter, and I'd say, by the way, we have 2 podiatrists that are separating. They're leaving the Air Force. And I'm going to need 2 guys or 2 women in the next 2 years. It's usually a 5-year cycle we do, but there's a need by someone leaving. And I think what they've told you is right now, they have no accession to come in because they don't have an open slot. But I know in the Air Force, the latest I know, there's only 19 positions. Okay. So unless some of them are leaving, you know what I'm saying? Like if one's leaving this year, one's leaving next year, then there'll be an opening each year, but it has to be the year you're graduating. Okay. See what I'm saying? And the only thing I'd be concerned in your case is if you graduate when is your graduation date?
2024. Okay.
Suppose at that point, there's no open positions. I don't know what happens if you've been in the scholarship program, if you're committed somehow just to be a quote officer in the service. I'm not sure of that now, if things have changed, but I think that's what they're telling you right now.
Okay. Thank you so much. I'm sorry for.
No, let Pat answer for the Navy.
I hope your battery holds up, Alex.
That's it.
About going to Buds. So you definitely want to talk to Ray Fritz about Buds, but also my knowledge of the current number of billets in the Navy is obsolete, but it does change, and it's a constant political battle between the different services and between the different corps, like the Medical Corps, Medical Service Corps. There's a thing called DOPMA, the Defense Authorization for Military Officers Act, that determines how many military officers there can be per year.
Each year.
And I worked at the Pentagon for a few years, and we looked at this stuff. I was in plans, operations, and medical intelligence, and I was also an anti-terrorism training officer in that billet. And we would look at like how many podiatrists we think we need on, for example, a new amphibious medical ship. And it's a constant fight. How many billets we get, they're just so much, there's this pie, you can only take so many slices out of it. So, and that changes from time to time. Generally, we have so many applicants into the Navy that we don't need to recruit. They don't need to give them bonuses. They don't need to pay for their podiatry school. They just say, pick the best ones and turn them into naval officers. And that may change from time to time, and the world situation and the needs of the service are what drive that. So what I think it's incumbent on anybody still on active duty right now, maybe some of us old guys, to keep pushing Congress and keep pushing our respective services and the DOD itself to realize the value of a podiatrist. In 1986, I wrote a paper that was published in the journal Military Medicine, and it was a letter to the editor, but it talked about, in my hubris as having just graduated, I said, you know, a podiatrist is probably one of the most valuable guys you can have in your forward position hospital, in your fleet hospital. Because this is a guy or a woman who can probably run the hospital because they've been forced into administrative positions, whether they like it or not. And they can probably assist every other surgeon in the place on any kind of procedure, head, neck, doesn't matter. And 3/4 of combat trauma is lower extremity. Always has been since as long as such things have been recruited. And there are other things than trauma. So there are 4 dreaded Ds of the field commander: direct hit, dementia, dysentery, and dermatitis. 2 out of those can hit your lower extremities. Jungle rot took out so many Vietnam combatants. The #1 casualty in the Falklands crisis was immersion foot. They took all these British soldiers and they put them off Argentina, and they had this little war, and they were standing in cold, wet trenches. You stick your foot in a cold, wet trench for about 24 hours, you're going to be in a hospital bed for the next 3 weeks. And so your utility to the military is huge if someone's smart enough to create enough billets to put you in one. And right now, we're still cheaper than medical corps guys.
Yeah.
We do get specialty pay thanks to Commander Fritz, but we still are less expensive than a medical corps officer, and probably more valuable than a lot of medical corps specialties, certainly in a forward position. So talk to your congressman, talk to Fritz. Don't give up your dream. Go out there and fight for us. There's plenty of fights out there waiting for you.
We might have time for one more question, guys. We're in the home stretch here for part two. Anybody have any other questions? Joe, I'm going to give you last word. What would you like to share clinically that you think might be important for, there are a few students here too amongst the crowd, that just things, maybe again, back to the overarching sort of, you know, the very direct way that you handled things when you were doing stuff in the military. What are some I guess, like a final piece of advice you would give?
Well, one thing I would give to students is every day, read one article for 15 minutes. I think if you're in school, that's something I wish I did more of. Read one article from a DPM journal, an MD or DO journal on something related to your profession. I also think that we have to become, if we aren't, a part of a larger team of treating patients. We're not just, again, with blinders on, that we only look at the foot or we only look at the ankle. I think we have to do the whole body. That's one thing in the military and the VA you'd be able to do. And I'm a big recruiter also. And I think from a clinical end, that's kind of overarching for me. But
well, I like the idea of collaboration, and I was fortunate. I got a little bit of that at NIH. I was in a rehab unit. We had an orthopedic surgeon, physiatrist,